We'll first just start with with all the DD waivers. We have individuals that are enrolled in the level 1, the self, and the IO that all require some sort of a nursing task, or not all of them, but we have a large population that requires nursing tasks. Doesn't necessarily mean that we put nursing in to provide all those needs, because we have other health-related support, such as we have non-nursing, that is unlicensed staff, who can, with training, there are different levels of certification that can meet medication administration needs. Then we have unlicensed people who, with the help of delegation from an RN, can perform certain tasks as well. And then, of course, we have nursing services that can be provided both through the Medicaid state plan program as well as the waiver program. If nursing is to be approved, that means that those services must require the services of the skill of an RN or an LPN who works at the direction of an RN. So we have different types of providers. We have a Medicare certified agency, which is provider type 60. And then we have other accredited agencies. This would be like if you have someone that's been received their accreditation from the Joint Commission, then they are what they could classify as a provider type 16. We have DODD certified agencies, and they are the provider type 45. And then, of course, we have non-agency or independent providers who are the provider type 38. Anyone who's providing a nursing service that's going to be billing for that service must have a provider agreement with Medicaid, because the nursing visits are billed through MITS and not through the EMBS system through DODD, but they require a billing number through Medicaid in order to use their MITS service. So when the county boards, when they're making their determination of services and who and what service would be the best to meet the needs of that individual, they do what we call payer sequencing. In other words, looking at the needs of this individual, can they be met through whether that be level 1, or if you have a level 2, which would mean that you have medication administration through the gastrostomy or jejunostomy tube, and then 3 being insulin. Some of those certifications require delegation as well, but they would be processing that of what can meet the need of this individual, or do we need certification plus delegation, or just delegation, or should we utilize state plan services? In other words, people frequently say state plan, but there's actually 2 different programs in state plan. There's state plan home health, and then there's state plan private duty nursing. State plan home health also includes Health Check, which is a program specifically designed for people under the age of 21. We also have benefits allowed to everyone if they require hospitalization and they're admitted for over 3 days. Then anyone with a Medicaid card has post-hospital benefits available to them if warranted. And then, of course, the PDN services is for continuous. And if they don't meet the criteria for any of the state plan home health or state plan PDN services, then if you're enrolled in the IO waiver, then waiver nursing is an option for you. Waiver nursing is currently only provided in the individual options waiver. It's not available in level 1 or in the self waiver. All right, and I think I just said that is the state plan home health, which is intermittent. Intermittent meaning any nursing visit that is less than or equal to 4 hours in duration. As I said, state plan home health is available to anyone enrolled in any of the waivers, but waiver nursing can only be provided through the individual options waiver. I mentioned earlier that we have medication certification. We have level 1, that is for oral and topical medication administration. Level 2 would be for those medications that are to be administered via a gastrostomy or a jejunostomy tube. And then level 3 is the administration of insulin. You must always have level 1 certification but you do not have to have level 2 or level 3 unless you have an individual that has that need. In other words, you don't have to have level 1 and level 2 in order to administer insulin, get level 3. You can have a 1 and a 3 or 1 and a 2, whatever meets the needs of that particular individual. And then we have delegation, and that is if you have a task that meets, that it's appropriate, the individual has a stable condition, the non-licensed person has demonstrated competency in meeting the need of that task, and you have an RN who is willing to delegate that task to that individual, then we can have delegation of that particular task that can go to a non-licensed person. Currently, there's the health-related tasks. When the HPC provider completes certification, medication certification level 1, they're also allowed to do health-related tasks, and you can see that these include vital signs, clean dressings, measuring INO or intake and output, oral suctioning, pulse oximeter, compression stockings, collection of specimens, emptying and replacing ostomy bags, glucometers, external urinary catheter care, that's CPAP and BiPAP for those people who are using it for sleep apnea, and use of a cough assist device and insufflator, and then, of course, application of a percussion vest as well. So we'll first look just at state plan services. And again, state plan services, there's two different types. So we can't just say state plan because it can be state plan home health, meaning that it's an intermittent visit, or it can be state plan private duty nursing, or you may hear a lot of people just refer to it as PDN, and that's for those individuals who have a continuous need for nursing care. That would be for a shift that's greater than 4 hours in duration. State plan home health includes health check and post-hospital, and it can also include increased state plan services for adults. In other words, typically state plan home health, there's a limitation of 14 hours per week. However, there is a method to get more hours approved to go more than the 14 hours if that's needed. There's an application currently it's through KeyPro, where the Medicare certified agency would request the increased hours. They would provide whatever supportive documentation is needed to back up the reason for to substantiate their reason for the request, and then increase over the 14 hours per week may be approved. And then we have, of course, state plan PDN, or private duty nursing, which also includes, there is a PDN post-hospital, again, for those who meet the requirements. If you've stayed 3 days overnight, I should say, in the hospital, and you need up to 56 hours per week, that is allowed for those people who have a Medicaid card. So state plan home health, we'll look at that first, and that is for those people who have an intermittent need. That is for those that require a visit of less than or equal to 4 hours in duration. It includes state plan home health aid visits, home health nursing, and skilled therapies. That would be like physical therapy, occupational therapy, and speech therapy.
Donna?
Yes, ma'am.
Can you get closer to the mic? I think people are hearing you very low. Thank you.
Better?
Yes.
All right. Again, if you have state plan home health, anyone with a Medicaid card, you need a Medicare certified agency to provide that service. They'll do an assessment. They receive physician's orders via what we usually refer to as a 485 or the plan of care, where it's ordered and those services can be provided. So again, plan home only to be provided on a part-time or an intermittent basis, which means that they cannot have, and this is where it gets a little bit confusing, they cannot have more than a total of 8 hours per day of home health nursing, aid, and therapy. So you have to look at how many hours of nursing, how many hours of aid, and how many therapy hours you're going to have falling on one day. But then there's also that you cannot have more than a combined total of 14 hours per week. However, in that 14 hours per week, that only includes the services of aid and nursing, not therapies. So therapy is added in on the limitation of 8 hours per day, but it is not included when you look at the 14 hours per week. So typically there is a limitation for those people over the age of 21 of 14 hours per week, with the exception of increased home health services via Pro we talked about earlier. Visits cannot be more than 4 hours in duration, and if you are to provide services of the same scope, in other words, if I'm going to have a nursing visit and then I'm going to have another nursing visit, there has to be at least a 2-hour break between the end of one visit and the beginning of the next visit. So if I have a nursing visit from 8 to 10, I could not schedule another nursing visit until 12 noon because they're of the same scope. However, if I had an aid visit, a state plan home health aid visit from 8 to 10, I could immediately follow that with nursing visit at 10 a.m. and have it 10 a.m. to 12 noon because they are of different scopes of care. But if they're the same scope, you must have a 2-hour break. Again, state plan home health can only be provided by a Medicare certified home health agency. If the individual is enrolled in a waiver, then those services must be included in the ISP or the individual support plan in order for the agency to be reimbursed for their services. So we please have to be sure that anyone who is enrolled in a waiver and they're receiving services, whether it be state plan home health or any other service, that the county board is made aware of that and that they are included in their ISPs. Now we talk about health check, and that's for those individuals who are under the age of 21. They're not 21, they're under the age of 21. If you're going to utilize health check services, and remember, health check is state plan home health check, meaning it's an intermittent service. So for those people under the age of 21, they must have at least one skilled service per week. Doesn't necessarily mean it has to be nursing, but it has to be skilled, whether that be a therapy, ST, or PT, or nursing. They must have a comparable institutional level of care. If an individual is enrolled in a waiver, then they have met that criteria of the level of care already. Again, there's rules around when you're ordering services that they must have a face-to-face encounter with their physician, either 90 days before or 30 days after the initiation of the service. Again, it can only be provided, just like with state plan home health, it can only be provided by a Medicare certified agency. The services cannot be used for rehabilitation or respite. Any state plan home health service, whether it's health check or just the plain state plan home health, it cannot be provided for respite. And sometimes in our mind when we think about respite, we think about, oh, well, somebody's going on vacation. But the definition of respite from the Department of Medicaid says that anytime a care is provided in place of the primary caregiver, because that primary caregiver is in lieu of relief or absence, that's considered a respite visit. So if you have an individual that the parents are providing a skilled service when they're home, like early morning before school, and then they provide it in the evening time, this is something that they normally do, but because they go to work and this task still needs to be performed, that would be considered a respite visit because the primary caregiver accepts that responsibility and performs it on a daily basis, but they can't perform it during certain hours of the day because they're away from the home and they're at work. So we have to be sure that we meet the criteria anytime we're assigning state plan home health, that we meet the criteria of the visit. Again, you have to have a 2-hour break if it's the same scope of service, and the visits have to be less than or equal to 4 hours in duration. Remember the limitation of 8 hours per day, and not to exceed 14 hours per week, with the exception of, with health check, you can't exceed 14 hours per week. 14 hours per week, the limitation is just with state plan home health. Those that are under the age of 21, if you need greater than 14 hours per week, as long as you meet all of the other criteria, in other words, you can extend the number of visits or you can extend the amount of time that they have, but you cannot extend the length of the visit. In other words, I may use 28 hours that week, but those have to come in increments of 4 hours or less. And when you use when you're doing your billing for state plan home health check, you must use the U5 modifier. So they'll use the G code, which is that G0299 or G0300, which is a state plan home health visit, along with the U5 modifier indicating that this is a health check visit. Because if that's not there, when MITS counts up to 14 hours, payment's going to stop. But with the U5 modifier, that indicates to the MITS payment system that this is a health check, so remove that 14-hour limitation, and it will be paid. Post-hospital, again, just briefly, that is for those people who are admitted into the hospital for a length of at least 3 overnight stay. When they go home, their services, if they're over the age of 21, you don't have that 14-hour per week limitation. They can go up to 28 hours per week. Again, there must be at least one skilled visit one time a week, and they can have that up to 60 days. When the Medicare certified agency were to bill for this service, they would have to remember to include the hospital discharge date in their remittance statement for their billing. Otherwise, they will be stopped. There will be no payment after 14 hours, but they have to have the hospital discharge date. If for some reason that individual is discharged from the hospital and they are admitted into a rehabilitation center or a skilled facility, and for whatever reason, and then they're discharged home, the amount of time that they spend in that rehab or skilled nursing facility, those days count towards that 60 days. So if I'm discharged from the hospital and I go to a rehab center and I stay 20 days and then I go home, then I'm actually going to only be allowed to have those additional hours for 40 days rather than the full 60, because the provider would still need to use the hospital discharge date, not the rehab discharge date. And again, for those people who are over the age of 21, although that we have a restriction of 14 hours per week currently, if there is a need and all of the visits would meet the criteria of a state plan home health service, then there is a potential that more hours could be granted, but that would require a review and an approval with a prior authorization given. Currently, that contracted agent is KeyPro, but it's through the Department of Medicaid, who's currently using KeyPro for their reviews. So there is the possibility to have more than 14 hours per week for those that are over 21, but there is a particular review process. If you have any questions about, because as we've kind of gone over them, you can see there's a lot of, you can have this unless you have this, and so it can get a little tedious, but there is, if you go to our website, both with DODD as well as the Department of Medicaid, there is a services, what they call a services at a glance, that will give you all of the criteria that we just went over as far as who can be the provider, what's the limitation of the visits, what's the limitations per week, who's allowed to, what do they have to have with respect to visits. Anyway, all of that information is on that website that's on the Services at a Glance tool. So I would encourage you, if you're not sure, to go there and get a copy of it because it's very handy to use. Okay, then we have state plan private duty nursing, or what many people just refer to as PDN. And a PDN visit, of course, is a continuous nursing visit. That means that the individual requires continuous care, meaning greater than 4 hours in duration. A service is not considered a PDN service just because a nurse is performing that. In other words, there's a difference between a person needing continuous care and needing continuous nursing care. We frequently get incidental care becoming the majority of the visit, the bathing, dressing, grooming, toileting, mobility, and then interspersed with, oh, and I'm going to put a catheter in, or I'm going to suction you, or I'm going to monitor your vital signs. But that's not the majority of the visit. So you're providing care, but we have to be sure that we're looking at the difference between care and nursing care. Incidental care can be provided through a PDN visit, but it needs to be just that, incidental to the scope of your practice needs to be nursing. In other words, if I had someone with a trach and mechanical ventilation, and I'm suctioning and I'm doing a respiratory assessment, and then in between, I may give you a sponge bath, and then I'm suctioning, and then I'm measuring your vital signs, and I'm listening to your lungs, I'm just sort of making this up, but you understand that my bath was incidental to my nursing. It's not that I gave you a bath and then I also put your catheter in. That means that it required 5 hours for me to do that, but the majority of my visit was spent on personal care. Then the personal care is not incidental. It's the nursing care was incidental to the personal care. A PDN visit, as I said, must be greater than 4 hours in duration, but less than or equal to 12 hours in length, but that's only for one nurse. In other words, that doesn't limit the individual from receiving more than 12 hours. It limits one nurse in a 24-hour period. That one nurse cannot provide more than 12 hours per day unless there's an unforeseen event. In other words, if I was providing care and I had worked 8 hours and the person that was going to come in after me was in a car accident, obviously we couldn't foresee that, and so I may stay on because there would be no other nurse available to come in and relieve me. Then I'm allowed to stay up to a maximum of 16 hours. Again, with PDN, we have to be sure that it's appropriate to the individual's diagnosis, their functional limitations, and that it's we include it in our plan of care. And just as I said with the state plan home health, it needs to be included into with a county board. They have to include that in their ISP before whoever the provider is, whether it be a non-agency provider or what they call it, the other accredited agencies or Medicare certified agency. They must be included in the ISP, or else those visits would not be reimbursable. How do we know when we're going to have a PDN authorization? Again, PDN can be utilized for individuals enrolled in any of our waivers, whether it's a level 1 itself or an IO. But if they have a continuous nursing need, then a nursing task assessment form is going to be utilized, and this is going to be done by the county board. The county board's not performing an assessment. The county board person is not determining what services need to be provided. The county board is going to account for what services are being provided and who's currently providing them and what time are they being provided and how long do they take. So again, although it uses a nursing task assessment form, don't be confused that means that the county board person is performing an assessment. They are only collecting the information that's related to the tasks that are currently being provided to that individual. When a county board completes their nursing task assessment and they believe that nursing is appropriate, let's say that this person has nursing in place already, and they believe that there is a need based upon their utilizing the assessment tool that is going to be a continuous need, then they would submit that to DODD, and if DODD requests, or they're frequently, the county board will go ahead and just collect what we call supportive documentation, which will be like the nurse's notes, the plan of care, the medication administration record. If the individual has a seizure log, let's say that they have frequent seizures and this is all being recorded, and as well as the treatment that's being provided, all of that substantiates the need for the nursing care. So that either will be requested by the county board or it may be requested by the in order to substantiate the need if there is for continuous nursing care. Just as we did had with state plan home health, you have a post hospital. There's also a benefit post hospital with the PDN service. Again, you must meet a level of care. You have to be admitted to the hospital for at least 3 overnight stays. If you've met that and there is a need for nursing, anyone with a Medicaid card can have up to 56 hours per week for a maximum of 60 days. And just like we talked about with the state plan home health, is that if you, for any reason, were discharged from the hospital to a rehab center or a nursing facility, and then you're discharged home, whatever time that you spent in that rehab center must be deducted from the 60 days that you're given when you're discharged home. Again, the provider would need to include the hospital discharge in order that they be compensated for that service. And if, when we talked about it early on about the payer sequencing first, can the needs be met through medication certification? Do we need delegation, either singularly or along with the certification? Or do we need to utilize, if they do have a state plan, they do have a nursing need, can those needs be met through utilizing state plan home health or state plan private duty nursing? And after we've used all those or we've eliminated those, then we say, if you're enrolled in the IO or the individual options waiver, then there's the potential of utilizing waiver nursing services. But as I say, it's only in the IO. It's not available in the level 1 or the self-waiver at this time. And this more or less says what I just said, and that is, this is our rule, OAC 5123:2-9-39, that says that waiver nursing is going to be authorized only if it can't be met through med-admin, with or without nursing delegation, and then, of course, state plan nursing services. State plan in general, that is, it could be either state plan home health or state plan PDN. Waiver does not include RN assessments. Now, RN assessments, that is a billable service, but it's not paid for through the waiver. An RN assessment is billed through MITS, but it's not taken from the waiver funding. Same thing with the RN consultation. If you've got someone that's receiving waiver nursing and they have an LPN that needs to consult with the RN is allowed to bill for that service, but it's not coming from the waiver funding, but it is billed through MITS. Delegated nursing is a billable service, not currently, but it's coming really soon in February, and that also is something that's going to be billed through MITS, but it's not. That is for nursing. But at any rate, and then of course there is waiver nursing that's not paid for, nor supervisory visits.
Donna?
Yes?
Just give me people listening from the phone, can you please mute your lines using *6 so that we don't hear any background noise? Thank you.
Okay. All right. So this with the waiver nursing, again, they're going to complete that nursing task assessment form, and then they will submit a service authorization to DODD, and that's going to be done at least on an annual basis. They'll be done initially and then annually thereafter. Or if there is a significant change of condition of that individual that may require a change in service that they're receiving, then they can, again, DODD would expect that a nursing task assessment and then all those things that I described earlier with respect to supportive documentation would be sent to DODD for their review, and then either an approval or denial coming from DODD. These are nursing tasks that can only be performed by an RN because typically we do not care, we being DODD, we're reviewing and authorizing nursing, not necessarily we're approving an RN or specifically an RN or specifically an LPN, but just nursing in general. However, there are some tasks that can only be performed by an RN, and this is based, again, upon rule, the 39 rule that I referred to earlier, and that is for IV, whether it's insertion, removal, IV med-admin, pump programming, anything to do with the central line, and of course blood product administration. Those things must be performed only by an RN. Plan of care, again, this is the the 485 and all the initial plan of care as well as all the subsequent plan of care should include the type and the frequency and the scope and duration of the waiver nursing that's going to be performed. When the waiver nursing services are performed by an LPN, we need to be sure that we have an RN that's overseeing that. So if you've got a non-agency LPN, that non-agency LPN must have an RN supervisor, of course, because they always work at the direction of an RN. The plan of care should be certified by the treating physician initially and then at least annually thereafter. Now, there may be agencies that have their own particular rules as far as how long a 485 or how long a plan of care needs to be reassessed and redone. DODD is not dictating their policy. They have to follow their own policy. But for DODD, we're saying that plan of care needs to be updated at least annually, and then, of course, with any significant change of condition of the individual. But again, we're not dictating the practice of an agency. They follow their own agency policy. The nursing budget process, we're going to have the same rate structure. So what an RN, an LPN, agency or non-agency paid through the Ohio Home Care Waiver is the same as paid or paid through State Plan Home Health will be the same pay structure that we receive with waiver nursing. The claims are going to go through MITS. That's why everyone has to have an ODM provider agreement so that they're able to bill MITS directly. Does not go through the DODD billing system, but goes directly through MITS. The county boards do have access to the billing, and that's through our data warehouse that they can receive. So if there's a billing issue or a service provision issue, the county board would have access to the data warehouse to be able to see what visits were performed and by whom and what was being billed to the state of Ohio. The billing codes are the same, again, just like with the Ohio Home Care Waiver. We use a T1002 to indicate a waiver RN visit. We use a T1003 for a waiver LPN visit. A T1000 with a TD modifier indicates that this is a State Plan State Plan PDN RN visit, and a T1000 with a TE modifier that indicates that it's a PDN LPN visit, and then the G code, the 0299 is the RN, G0300, of course, is the LPN, and you would need to use the U5 modifier again with health check, meaning that this is a person under the age of 21, more than 14 hours per week. And be sure to remember that you would have to include the discharge date if we were utilizing post-hospital services, whether that's for a post-hospital PDN or post-hospital State Plan Home Health. Just want to give you a quick look at the nursing task assessment form. Again, this is something that is done by the county board or its contracted agents, and it's done at least initially and every year thereafter. Or, of course, if there was any significant change of condition that would cause a change in the services, then we would expect the nursing task assessment form to be completed and submitted again. Along with the NTA, or the nursing task assessment, they also include a proposed schedule. This usually includes, if you have someone that's under the age of 21, frequently includes a school schedule plus a summer schedule. So the task or skilled nursing task assessment tool, again, the county board person is not performing the assessment. They're assessing the services that are already in place. So they were going to identify what skilled services had been ordered by the physician, which is why the county board person will be reviewing with the nurses, if there's nursing in place already, the plan of care, and look through the interventions, what has been ordered, and then there will be an accounting of those services that have been physician ordered will be accounted for on the nursing task assessment. And they're going to identify who is currently providing this service, whether it's mom, dad, grandma, next door neighbor. It could be met through an HPC provider. with the proper certification or delegation. It could be nursing is providing this. It could be mom is providing it now, but she's going to go back to work, and so this is going to be an absence that we're going to have to fill through an alternate means, whether that's through an HPC provider with the proper training, or if it's going to be filled back to nursing. And then, of course, the question is going to be, is waiver nursing going to be requested? There's a classification 1 and 2, and that is, and I'm going to show you just in a second here, I'm going to show you a picture of what our nursing test assessment looks like. If you see a classification 1, that just says that if the county board is requesting nursing, we would say that that is a test that would probably require nursing, and so there would be no further question from that. If it's a classification 2 and nursing is being requested to perform that particular task, then there would have to be some sort of an explanation as to a particular complication that would prevent this task from being, if it's a task that's typically met through certification level 1, then we would need to have some sort of an explanation, not anything long and drawn out, but just a brief description of what's the complicating factor that means that nursing needs to be utilized as opposed to using a non-licensed or HPC provider. This is just the top part. It just gives you like demographics of, the waiver span, who the individual is, who's present during the assessment, and then date of birth and blah, blah. This is just demographics of the individual. And then this is just a little snippet to show you. You see those classifications 2 and 1, and you see the red arrow pointing to how are the current needs being met now. There is a drop-down box, and I'll show you in the next slide, that the county boards can use. And then, are you requesting waiver nursing to perform this task, yes or no? And that's the drop-down box that I was telling you. And they may have to use more than one. You see this as, for this particular task, it's got an RN, or an LPN, RN delegation, or it's unpaid natural support. The parent's performing this all the time. However, for whatever extenuating circumstance, they're not going to be able to. So how's the need going forward? How do we need to meet that need? And again, this is just a reminder that this is not an assessment that the SSA or the county board is performing, but it's only an assignment of the tasks that are currently ordered. Again, utilizing your 485, and then we will look at the nursing documentation to make sure that what's being ordered in the 485 or the plan of care is actually being done and documented as what we can find in the medication administration records, through the nursing documentation, through the logs or whatever supportive documentation they have. That will all be used to say, yes, there is a need. It's supported through, yes, it's being performed, because here the medication administration records saying that this has been done on a daily basis, 3 or 4 times per day, based upon the need, whatever it is, to substantiate the request. And this goes over that. There's a review of the documentation. There may be additional, and I've talked about that already. That is the nurse's notes, the MARS, the TARS, seizure logs, oxygen saturation measurements, and any documentation that's pertinent to the care of that individual. We do have and I touched on this briefly earlier, where you do get the RN assessment and the RN consultation. This was started, I think, last year, where the RN, when she's performing the assessment visit, that she's allowed to bill through that, and that is billed through MITS. Again, that is, the RN is doing an assessment and planning one plan of care, so it's not, the RN doesn't bill the LPN that she might be overseeing, but it's one assessment of that individual and makes one plan of care. And then, of course, the consultation meeting, that does not translate into supervisory visits. That translates into an LPN is providing the care, and there's been a change in condition that may warrant a change of intervention. And the LPN, because they do not practice independently of an RN, but they contact the RN to discuss the current condition, The potential complications, the RN either gives direction or contacts the physician, gets a change in the order, and then gets back with the LPN to share the change of the order. That's all done. The RN is paid, and that's considered an RN consultation, and she's allowed to bill. Again, this is through the MIT system, that she's allowed to bill for that time that she spends giving that advice or giving the instructions to the LPN and contacting the physician and making the change in the interventions accordingly. So please don't get consultation mixed up with RN supervision visits. An RN is not a billable visit to do your soup visits. As I said earlier, there is going to be an RN delegation, an assessment and consultation, not to be mixed up with the nurses. This is for those people who are overseeing non-licensed people, and it also will be done through the MIT system, but more training will be coming on that soon. Managed care, as we all know, that January the 1st of this year, DoD waiver individuals may enroll in a managed care program. There's no mandate that they must, but they can. Before now, they were not included in the HMOs or managed care, but as of January this year, they are permitted to. Knowing that, then the county board and the providers need to be sure that they stay abreast of any changes that the individual may make in their Medicaid status, because if they're enrolling into a managed care organization, then we need to be sure that we understand that the managed care program makes that determination with respect to authorization for state plan, home health, state plan, PDN, anything to do with their durable equipment. All of that comes from the managed care program. That's not something that can be done independent. They make that determination of the services, the service hours, and the service providers. I believe that the providers of that, they have to have a contract with that particular managed care program. So we need to be sure that we want to work in collaboration with them. In other words, they should be contacting the county board. Again, we want to be sure that that service is included in our ISP, because if I'm the SSA, I want to know, well, what services outside are being provided so that I know how I may need to augment those, or I don't need to provide someone because it's already being provided through the managed care plan. So make sure that we know who is enrolled in a managed care plan, and if they require services, remember that authorization needs to be through them. If an individual is enrolled in IO waiver, they can have waiver nursing in addition to their state plan through the managed care. However, I mean, there would be a lot of, have we gotten back in touch with the managed care plan? Do they know that there's been a change? I mean, there would be conversation around it, but I just don't want you to think that they would never be allowed. There may be an odd situation that would allow waiver nursing in addition to what would be authorized through the managed